talk in the coming 30-35 minutes. And the icebreaker, well, that was also something new. I think in our forum meetings also we need to come up with this icebreaker idea. There's a consolation prize from my side, a question from my side to the participants, and I request the admin to please take a note. Why is 14th November celebrated as World Diabetic Day? Any particular meetings also we need to come. Anybody can you answer on the chat box? And if somebody has answered, then there's a supplementary question to it. Admin, anybody answered? The admin is not there, I think. And if somebody has answered,
2000, nobody answers so far. Chat is open.
Okay. In 1922, the wonderful drug insulin, which saved lives, was discovered. And one of the scientists who discovered, Frederick Banting, his birthday falls on 14th November. Along with Charles Best, he had discovered insulin, which was a life-saving threat and still now life-saving drug. In type 1 diabetes, without insulin, the person cannot go further in life. So with this very small introduction, I will just share my screen and start off my presentation. Yeah. And all of you have seen that circle, blue circle outline. There's a purpose. This is the World Diabetes Day IDF logo. And blue color and circle because diabetes is a universal problem. It's a problem which is seen all over the world. It's not limited to any particular geographic area. And the blue color is this color of the sky, which goes to show that we all need to join hands to fight this. In the introductory speech or in the presidential address, somebody mentioned it's an epidemic. Yes, it's an epidemic going to epidemic scale, So all of us, if we join hands together, we can definitely be able to win over diabetes. Yeah, these are some of the very small facts why we are discussing about this. Worldwide, this is very important. Worldwide estimates that 50% are undiagnosed. So when we say 2019, 463 million adults have been diagnosed with diabetes type 2, there are 50% who have been undiagnosed. So a lot of efforts need to be done with screening and trying to catch the diabetics early. This is one. In Kuwait falls among the top 10 countries as far as diabetes is concerned. Nearly 1 in every 4 adults is a diabetic. And here, right there, 463 million in 2019 and 700 million by 2045. So it's a huge problem, a big public health issue, and all of us need to join hands to fight this. Yeah, this is the world map showing you, where all here we have 463, which is likely to go up to in 2045 to 700 million. If you look at the developed countries, the 15%. 31%, they are less. But when you come to Africa, 143%, 96%, 74%, that is the increase. So we got to be more focused. But Europe and North America, if you see, the percentage of increase is only 15 to 33%. So what exactly is diabetes mellitus? All of you know. Diabetes mellitus, it is a metabolic disease. And in that you see high blood sugar levels. The glucose levels are very high. And the prime reason being either there is defect in insulin secretion or the insulin is not able to act, or there is both, a combination of both. There are many different types of diabetes, many varieties of diabetes. I'm going to type 1 diabetes, or otherwise known as insulin dependent diabetes, type 2 diabetes, the normal common diabetes that we all talk about. And then there are other types of diabetes, but worth mention is gestational diabetes. That is diabetes seen among women who are pregnant. This is an organ within our abdomen, pancreas. Pancreas is a small organ within our abdomen. And in the pancreas, we have these special cells. These cells are known as islets of Langerhans, and they contain beta cells. See, within the abdomen, this is where the pancreas is. In the pancreas, you have Langerhans cells. They contain beta cells, and it is this beta cells which is secreting insulin. So that's the very basic. Now, our body is made up of billions of cells. You take the skin, billions of cells. Take the eye, billions of cells. Heart, millions of cells. So each and every organ, each and every part of our body is made up of millions of cells. For these cells to survive, they need energy. And to produce energy, you need glucose. And from where do you get this glucose? We get this glucose from the food that we eat. So once the food that we eat enters into the bloodstream, then from the blood, this is the bloodstream. This is the bloodstream where the glucose is. See, bloodstream. From the blood, the glucose has to enter into the cell, into each and every billion cell that I spoke to you about. And for this glucose to enter into the cell, you need insulin. The very first step is insulin is needed. Insulin will go and bind to a receptor. So this is like a lock and key. Once the insulin binds to the receptor, that is, the key is unlocked and the glucose will enter into the cell. And once the glucose enters into the cell, then it will undergo metabolism to give rise to the energy that is so very essential for the cell to survive. This is basically the importance of insulin, the importance of glucose. Now, for whatever reason, if this level of insulin is less, then the glucose will not enter into the cell and the glucose in the blood will be high and you get diabetes. Or if the insulin that is over here is defective or not able to join to the receptor, insulin receptor, and the lock is not opened, again, the glucose levels in the blood will be circulating in the blood will be high, and that condition is called diabetes. So there are a lot of risk factors. Some of these risk factors are very much under our control, but some others are not within our control. Like age is not under our control. Whether we like it or not, we keep aging. And as one ages, the risk of diabetes increases. So if somebody is in his 30s and other person is the same person when he becomes 50, 55, 60, the risk of developing diabetes increases. So as the age advances, the risk of diabetes increases. You don't have a choice on that. Even family history. You can't choose which family you're born in. And families where diabetes are common, there is a genetic element and they have a risk of developing diabetes. So these are race. Again, that's not under your control. But there are certain features like weight. Weight is very much under your control. It will depend on the diet that you take and the exercise that you do. To keep a balanced diet and a proper exercise will help you maintain your weight in the normal range. So weight and inactivity. Inactivity means lack of exercise. Again, there's no excuse for this. So these are two very important risk factors which is very much under our control and which will help us not to get diabetes, not to develop diabetes. So then there is geography, certain locations like if you know the Pacific island, Micronesia, we call it a group of islands, Micronesian group of islands. That is where the incidence of diabetes is very high. Then even in urban areas, when compared to village life, the people staying in cities, they have a higher risk of developing diabetes. Similarly, if somebody has got low vitamin D levels, again, he or she has the risk of developing diabetes. Gestational diabetes. Ladies who are pregnant, some of them develop diabetes. And most of them, after they deliver, they become normal. But then they are at a risk of developing diabetes at a later age. But some others, even after delivery, they continue to remain as diabetic. So pre-diabetes is a condition. Person is not diabetic, is not yet reached in the diabetic range, but he's at a risk if he doesn't properly maintain his weight and diet and exercise. such a person can develop diabetes. So a single slide on type 1 diabetes, because my talk is on the common diabetes or type 2 diabetes. Among all diabetes, 90% of the diabetes is type 2 or the common diabetes that we talk about. This is just one single slide on type 1 diabetes. It is otherwise known as insulin dependent diabetes. And the main reason they say is an autoimmune disorder. It's an autoimmune disorder where for some reason, maybe there's some trigger that makes your own immune system attack the beta cells, attack these beta cells. See here in this, these are the beta cells, and these beta cells are attacked, and then these beta cells don't function. These beta cells are supposed to release insulin, and here you don't have this insulin. Here you see beta cells releasing insulin into the blood. Here there is no insulin. Why? Because these beta cells have been destroyed, attacked by what? The person's own immune system. And therefore there is no insulin. So in this condition, if you don't supplement the person with insulin, the person is at very high risk and then ultimately dies. That is why I mentioned initially that in 1922, the wonder drug insulin was discovered, and that was life-saving. Type 2 diabetes, the 90% diabetes that we all know, common diabetes we talk about, that is non-insulin dependent diabetes mellitus. And previously it used to be known as adult onset diabetes, because when I used to 30 years back when we were in the college studying medicine, that time you wouldn't see a diabetic, type 1 diabetes you would see among children and teenagers and young adults. But to see type 2 diabetes, you needed somebody who was in his late 40s or 50s, 60s. Only if somebody became 50, then only that person would develop diabetes. But now, no. We are seeing type 2 diabetes among children, among teenagers. And this is a cause of worry, a big public health issue. And the reason behind this is, the reason behind children, teenagers, young adults developing type 2 diabetes is obesity. My coming slides will tell you what it is. See, there is something called insulin resistance. I told you the insulin has to get attached to the insulin receptor. That is a lock and key. Once it gets attached, then the lock is opened and the glucose can enter into the cell to produce energy and for the needs of the cell. There is something called insulin resistance, and the main reason for insulin resistance is obesity. Here there is insulin, but that insulin is not able to join with the receptor to get you the proper action. So you need more insulin to join with the receptor to open up the door through which the glucose can enter into the cell. So this is a lack of sensitivity to insulin, and the main reason is obesity. And as all of you know, obesity has become an epidemic worldwide. Globesity, we call it globesity, a new term. Here in Kuwait, at least 35% people are obese, if not more. So it's a huge problem. And then second is defective insulin or relative deficiency of insulin. For whatever reason, the beta cells production of insulin in type 2 diabetes, which contributes to worsening the glucose control. So type 2 diabetes or the normal diabetes, usually it is seen among obese individuals. Formerly, we used to say after 40 years of age, but right now, as I mentioned, it is seen even in younger age groups. And because of poor eating habits, lack of exercise, 90% of the patients have type 2 diabetes, and the remaining 10% are type 1 and the other types of diabetes. So now when we talk about obesity, how do you calculate obesity? There is something called the body mass index. This is the formula to calculate what is the person's body mass index. You take the weight in kilograms, measure the weight in kilograms, measure the height in meter, and then you square it actually. Kilogram by square meter height. And if the BMI falls between 18.5 to 24.9, means it is normal. Between 25 to 29.9 means the person is overweight. And above 30 means the person is obese. In that also we have grade 1, grade 2, grade 3 obesity. Grade 1 is between 30 to 34.9. Grade 2 is 35 to 39.9. And anything above 40 is grade 3 or morbid obesity. So obesity, one of the big risk factor is diabetes. There are many other diseases which are associated with obesity. Obesity is a risk factor to develop cancer and many other diseases. So one needs to, and this is how you measure the obesity. As I told you, weight, weighing scale, and the height. So weight in kilogram, and then you have for children, small children and all, you have this growth chart. You take down the weight and you take down the height and see where it falls. So you have this. And then there is this something called colored tape. Put it around your waist, and if it falls in the green, you're normal. If it falls in the red, the person is obese. The main point, the main emphasis, I'm sure all of you know about this. The main reason for obesity is bad or poor or unhealthy eating habits. And this is a common sight. Burgers, pizzas, KFC, you call it whatever it is. And there are reasons behind it, sweets and these cola drinks. Nowadays, what happens is both the parents are working. So there's no time to cook food. And, it's easy. Fast food is in trend. And fast food is, it's very addictive. You eat it once, you want to have it more. It's tasty. It is tasty. And then there are promotions. Pay 100 fills and you can upgrade it. So it's very attractive. It is tasty, easily available. You don't have to wait in the restaurant for 1 hour for your food to come in. Within 5 minutes, you have your food. So many things are there, and both the parents working. So all these, last 2 decades, probably these fast food joints have come. Every nook and corner of the street, you find a fast food joint. And that is one of the main reasons for poor or bad or unhealthy eating habits that contributes to obesity. The other is lack of exercise. This is a couch potato, but if, your child and my child, very common. This could be your child or my child, same. Unfortunately, when we were children and we were told, now don't watch TV, go play. Play means go outside, go to the ground, play gilli danda, play football, play or the kho, play, hockey, cricket, anything, play outside. Nowadays, there are no playgrounds. Here in Kuwait, the flats, buildings where we are staying hardly has any compound area, play area. So when you tell them immediately take a break means go and play with these gadgets, computer game, these. And these are remotes, because you and me, every one of us, you have remote for the TV, you have remote for everything, for the AC, for the fan also you have a remote. And nowadays nobody uses even the line telephone, the mobile is there. So basically no exercise, lack of exercise. That brings me to the next slide, which is symptoms and signs. So these are the main symptoms, passing of urine frequently. Somebody has to get up and pass urine frequently. Get up from the sleep and pass urine. That's a sign of diabetes. You have to get investigated and find out whether he or she has got diabetes. Somebody is extremely thirsty, keeps on drinking water, polyuria. The other thing, the frequently passing urine is polyuria. Frequently drinking water, extremely, polydipsia. This is main symptoms of diabetes. There is weight loss without any reason. Eating good food, everything, but the person is keeping on losing weight. That also could be reason. Weakness and fatigue, which cannot be explained, or an increased hunger. When somebody has got these symptoms, then has to should consult a doctor, screen to rule out diabetes. In the skin, if the skin is dry and itchy, there is something called acanthosis nigricans. Acanthosis nigricans is a blackish discoloration on the folds of your neck, folds of your axilla. People with acanthosis nigricans, which is black discoloration, they have a higher risk to develop diabetes. Blurring of vision, cuts and bruises which take a long time to heal, a tingling numbness sensation in the hands, leg and feet. If somebody feels any of these symptoms, then he or she should go consult the doctor and rule out diabetes. Well, investigations. Investigations are, you can do the blood test. You can, and there is something called the OGTT. So in blood test, you have the fasting. The next slide tells me that. Yeah. You have the fasting blood glucose level and you have a postprandial 2 hours after a heavy breakfast. So you do a fasting and then you take a good breakfast and then 2 hours following that, you do a postprandial. Okay. Then there is something that the American Diabetic Society recommends, like HbA1c, otherwise known as glycated hemoglobin test. Then the gold standard OGTT, oral glucose tolerance test. The others are all very insulin levels and antibody studies are all done by the super specialist doctors. Okay. Normal blood glucose level should be 80 to 120 milligram per deciliter. Otherwise here 4 to 6 millimoles per liter. And the normal postprandial should be 140 to 200, otherwise 7 to 10. Pre-diabetes are 100 to 126. So these are the range, normal range. And when it comes to oral glucose tolerance test, here what happens, a fixed amount of glucose, a measured amount of glucose, sweet drink is given, and the blood is checked every 2 hours. And then if you see OGTT, if it is less than 140 milligram, it is called normal. And if it is between this level, pre-diabetes, and more than 200, it is diabetic. Again, for this OGTT is also done for pregnant ladies, in which case it is every 3 hours and the test is slightly different. This is a very important test, HbA1c. Once a person is diagnosed as diabetic, then he or she must do an HbA1c once every 3 months. So 4 times a year. And in HbA1c, the target level should be below 5.7 or below 6.4, because up to 6.4 is 5.7 to 6.4 is pre-diabetes, and anything above 6.5 is diabetes. Now, what is this HbA1c? It's actually glucose molecule getting attached to the hemoglobin. Hemoglobin is found in our RBC. And this hemoglobin, the life of the RBC is around 120 days. That is why they say that if you measure the hemoglobin, glycated hemoglobin, the glucose attached to the hemoglobin, indirectly it can give you the blood sugar level. And that will tell you the average blood sugar that has been there in your body for the last 3 months, 3 to 4 months, the average level. So it's a very good test, recommended to be done once in 3 months to see whether your diabetes is under proper control. And even for diagnosis, if somebody does an HbA1c and if the HbA1c level is more than 6.5% or more, then the person is diagnosed as diabetic. So that brings me to the next slide, because one should understand that diabetes does not go away. Once diagnosed with diabetes, one should manage it well. Monitor the level and manage it. Maybe you can reduce your medicine levels, you can reduce the number of drugs that you take, or you can reduce the dose of insulin, or probably you can do away with the insulin if you're not type 1 diabetic. But diabetes just doesn't go away. So you got to have, and the goal, you see, it should be bullseye to maintain the target blood glucose level. That is very, very important. Very important. There are patients who come to me, they say, doctor, my blood sugar level used to be 18. Alhamdulillah, now I am 11, 12. I'm happy. It doesn't help. Even if it's 11, 12, this blood sugar level is continuously causing damage, and person can land with the complications. Those issues will be spoken to you by Dr. Yusuf. So my purpose of showing you this slide is, the goal is to maintain, and there should be bullseye. You should be in that normal range. That's very, very important. And how do you do that? It's a juggling act, continuously 24/7 juggling act. You have these 2 things which reduce your blood sugar level, and you have this which food intake will increase your blood sugar level. Insulin and oral medicine will reduce your blood sugar level. Exercise will reduce your blood sugar level. So if you can balance it properly, that is how you manage diabetes. And to take you forward, And to explain to you how to go about managing diabetes, I request Dr. Mohammed Yusuf Dar, our very esteemed senior member of the Indian Doctors Forum, a highly reputed physician. He's from Kashmir and he's been here for more than 2 decades. One of the few doctors who I hold him in very high esteem. And I request him to please come forward and take us through the management, treatment and management part of it. Thank you.
Assalamu alaikum. Good evening to everybody, all the people who are attending this webinar, and my humble thanks to all the people who invited me for this today's webinar. I must thank Dr. Amir Ahmed, who has made it very simple for me, because the way he has presented the diabetes for the common people, that has made my job quite easy. Now, as Dr. Amir Ahmed already pointed out, the burden of diabetes in the world, and we all know those figures now. We had the questions and the answers also. It's a huge, huge burden on our society, the burden of diabetes and the burden of obesity. And when these two things come together, they give us a lot of problems. That's why we need to manage them. To manage these problems, we need to have certain goals in our mind. So what are those goals? The three important goals are, we have to manage the symptoms. As you remember, Dr. Amir Ahmed just now presented the symptoms of diabetes. So we have to manage those symptoms. But here I am going to tell you that most of our diabetics are asymptomatic. It's only a percentage of people who come up with symptoms of polyuria, polydipsia, and polyphagia. Majority of the people, when we find them accidentally that they have got diabetes, it comes as a surprise to them, and they are not ready to accept it. They are in a sense of denial. And we all know that many of the diabetics in the world are still undiagnosed. 50% people are undiagnosed. So second goal of therapy is, we have to reduce and we have to prevent the long-term complications. What are those complications? Those complications, we call them microvascular complications and macrovascular complications. Micro means small. So it's a disease of the problem which is caused to the small vessels in our body. So where are those small arteries? Where are those small vessels? They are in our eyes, they are in our kidneys, and they are in our skin and other organs. And the macrovascular, where are the larger blood vessels? They are in our heart and in our brain and our peripheral arteries. So looking at these two things, the management of diabetes, when we manage these people, we have seen over the last 30, 40 years that when we manage diabetes very well, we can prevent or we can reduce and we can decrease the microvascular complications, and very little effect is seen on the macrovascular part of it. And third goal is, we have to allow the patient to achieve as normal a life as possible. So these are our three goals in the management of diabetes. So what the physician needs to do? He has to identify a target level of glucose control for every patient. You see, it's not, the goal is not same for every patient. Every individual patient behaves in a different way. So the goal has to be different for each and every individual, and that needs to be decided by the treating physician. So how do we do that? We provide the patient with education and pharmacological resources necessary to reach that target. We monitor and treat their complications. So it is a multidisciplinary effort. It's a team effort. The most important member of that team is the patient himself. Unless the patient gets convinced to follow the guidelines given from the rest of the team, we cannot succeed. That's why I tell my patients, the management of diabetes is not in my hand, it's in your hands. how well you respond to our guidelines, our instructions, that will describe how well you will do with your disease. The care providers include the physician, the treating physician, or it may be a diabetologist, or it may be an endocrinologist who is super specialized in these diseases. It is the diabetes educators who, from time to time, they give education about the diabetes to the patient. It is the nutritionist who decides about what type of diet and how the patient will manage his diet. The psychologists and the social workers, because when a diagnosis of diabetes comes in the family, they have a lot of anxiety. Some people get into depression, so you need a lot of psychosocial support, and that is given through the social workers. And then we need the subspecialties. When do we need them? We need the ophthalmologists, we need the neurologists, we need the podiatrists, we need the kidney specialists or the nephrologists, we need the heart specialists or the cardiologists, and we need the cardiovascular surgeons and the transplant surgeons, and sometimes we even need the dermatologists. Because the long-term the complication of diabetes, they do not come at the time of diagnosis. They come when the disease progresses. What we have seen, that when you diagnose a diabetes in a patient, a middle-aged patient, suppose he is 35 years old or 40 or 45 or 50 years old, he comes and you diagnose him as diabetes. Now, at this point of time, we don't know how long he has been diabetic. Maybe he is diabetic for 5 years, or maybe he is diabetic for just 2 months. So at the initial presentation, at the initial diagnosis of diabetes, you need to, number one, you have to clarify his diagnosis. And how do you do that? As Dr. Amir Ahmed told you, that we have to do his fasting plasma glucose, we have to do his postprandial or after the food glucose, and we have to check his hemoglobin A1C. The fasting plasma glucose has to be done at least on 2 occasions. The HbA1c, again, you have to reread it and see and make it sure that this patient, yes, he has diabetes. And the parameter, the readings, Dr. Amir Ahmed has already told you when to say that this patient has pre-diabetes or post-diabetes. I don't want to go into the repetition. Now, when we see this patient and he has diabetes, so at the first diagnosis, we also need to check his eyes. Because as I told you, we don't know how long he has been diabetic. So we need to find out that those investigations, those checkups can give us an indirect idea. Suppose if we send the patient to the ophthalmologist, he does a dilated fundus exam, he puts a drop of medicine into his eye and dilates his pupils and then sees inside. If he sees normal eyes, we say, Alhamdulillah, this probably is a recent onset diabetes. But if patient has already developed diabetic changes in the eye, then we are sure that this patient has had diabetes for a long, long time. Similarly, the other specialists, they usually come into picture later in the disease after, say, 5 years, 10 years, or even 15 years, depending upon how well we have managed this patient with diabetes. So what are the guidelines? So as I told you, the goals have to be individualized, and we have to make a therapeutic plan for every patient. We have to teach the patient how he will monitor his glucose. There are 2 types of monitoring. One is a monitoring with a glucometer, where every time you want to check your blood glucose, you have to prick your finger and get the machine and put the drop of finger on the strip, and you will know the glucose. And more recently, now we have got the non-invasive continuous glucose monitors, where you put the machine on your arm, and then you just take your mobile and you can do it 15 times a day. It's non-invasive, it's easy to check, and you can maintain a diary. You need to check your hemoglobin A1C, which has to be done by the care provider, by the physician, and it is done 2 to 4 times per year. 2 times in those people we can do with 2 times only where the diabetes is well controlled and the hemoglobin A1C is in the proper range. And more frequently we need to do in those patients whose hemoglobin A1C is still high. So those people, you need to do it every 3 months. And then we have to look at the lifestyle management of these patients. You see, with what happened in last 50 years, before 50 years, the diabetes was a rarity. In our social setup, it was rare to find a diabetic in a village. But with development came affluence. With affluence came the TV, and came the games, and came the cars and the other things. And we became lazy. So development gave us laziness. They gave us everything in our single room. and we became obese and we got diabetes. And development also gave us the management of these diabetics. So how do we do the lifestyle management? Diabetic education, the nutrition therapy, and the physical activity. So the diabetic educator will teach the patient how he should do with his diet, how can he go with the physical activity. Physical activity does not, as somebody in the introductory talk, he said, we don't need to go and join a gym. No, that's not the only thing we can do. We can do small things. Suppose you are going to the office, don't park your car as close to your office or as close to the shopping mall. When you go, park it little farther away so that you get a chance to walk a few steps. When you go, you reach your home, or when you reach your office, don't use the stairs. If your office or home is on the second floor or the third floor, take the stairs. Similarly, if you want to play, take your children out, go for a walk, play with children wherever you get a space. Don't play with the games with them in a single room. And then we have to give a psychosocial care. As I told you earlier, also they have a lot of anxiety and they have depression. So we have to manage those things also. And the prevention, detection, and the management of complications, where the subspecialties and the super specialties come into play. Eye examination is done at least annually or biannually. Every diabetic should have a chart that when did he have his last eye examination, and he should remember when the next examination is due. Similarly, in his file, which is with the doctor in the clinic, there should be a note when was the last eye examination done and when he is due for the next examination. Foot examination by the physician at least once or 2 times per year, but by the patient himself every single day. He should see the color of his feet. He should look at the skin. He should look at his shoes, whether they are well fitting, whether his weight bearing is okay. Because with time, when the patients with diabetes, when they develop neuropathy or the problem with their peripheral nerves, then they have loss of proper sensations. They cannot find out if the shoes are ill fitting or the weight bearing is proper or not. Similarly, neuropathy examination, you have to do by the physician. It has to be annually. The kidney disease testing, how do we do that? We look for the urine examination. We see the urine for albumin or the protein, and we do it at least once in a year. And if the patient has already developed albumin in the urine, then we have to do it more frequently. And then we have to manage and treat other relevant conditions. What are those? As already told by Dr. Amir Ahmed, obesity. You have to manage obesity, very, very important. And you have to manage hypertension. And there are certain other factors, like you have the patients who smoke. You have to guide them that smoking, because when these things come together, they don't just add up, they multiply our problems actually. If somebody is having obesity, he's having diabetes, he's having blood pressure, and he is a smoker, the problems multiply and the complications, they knock at our door much more early than later. And the lipids. By default, every diabetic should be started on lipid lowering agents. Why? Because the target of having a cholesterol level, or the target of having an HD, high density lipoprotein HDL level, or a LDL level, or a triglyceride level is not same for a healthy individual and for a diabetic. Because diabetes, we used to call them as coronary disease equivalent. A diabetic is as good as a person who already had a coronary heart disease, who already had a myocardial infarction. So the lipid values in diabetics are, the target is different than the normal people. And then we have to think of giving them antiplatelet therapy like aspirin. And we have to give them vaccinations like the influenza vaccine, the pneumococcal vaccine, and hepatitis B vaccine. You have seen in the last 8-9 months of this pandemic, of COVID pandemic, people who were obese, people who were diabetic, people who had hypertension, who had these comorbidities, they did not fare well. Similarly, people with these diseases, with hypertension, obesity, and diabetes, they don't do well if they have an attack of influenza or if they have an attack of pneumonia. So an influenza vaccine is recommended every single year for all patients with diabetes, and a pneumococcal vaccine is recommended every 3 to 5 years. And hepatitis B vaccine, everybody should get a hepatitis B vaccine, which is once in a lifetime, the 3 doses which are given at 0, 1, and 6 months. I already told you about the nutrition, exercise, and the psychosocial support. And the diabetes care during illness. When the patient is ill, he should know what he has to do. When should he contact the doctor? When can he manage himself? How much blood sugar he should see, and then he should contact the doctor or go to the clinic or go to the hospital. And he should have the knowledge about the illnesses which come, like the hypertension, like the dyslipidemias. Why? And this is a continuous process. This is not just a one-time encounter with the patient. Anytime the patient comes to your clinic, he has to be seen by the physician, he has to be seen by the nurse, he has to be seen the diabetic educator, and every time he comes, we have to reinforce all these things so that he becomes more knowledgeable. He develops the skills to monitor himself, to do his glucose testing, to take his medications, to take his insulin therapy, and it develops a trust between the caregiver and the patient, and he develops confidence. He should know how to monitor glucose. He should know how to, the children of the type 1 diabetes, they are very smart. They know how to do their ketones, and they know how to administer insulin. And they know how to manage their glucose before, during, and after the exercise. And they know if they go into hypoglycemia, what are the symptoms of hypoglycemia, a low blood glucose in the blood, and they know how to manage it. How they will know it? They will know it only when we educate them properly. So what are the goals for adults? Hemoglobin A1C, the goal is we have to keep it less than 7%. The American Diabetic Association recommends a HbA1c level of less than 7%, but the American Society of Endocrinology, they say if it's less than 6.5, it's all the more better. And the blood glucose, if we can maintain it between 4.7 and 7.2 millimoles, that is between 80 and 130 milligrams per deciliter, it's ideal. And the postprandial glucose, you can simply say the random glucose, it has to be less than 10 millimoles or less than 180 milligrams. And you have to monitor your blood pressure also. Make sure that your blood pressure is kept less than 130 over 80 millimeters of mercury. Your triglycerides should be less than 150, and your LDL cholesterol should be less than 70 milligrams. So what are the dietary recommendations? It's not an easy topic to discuss with the patients because it's so complicated. So broadly, we advise the patients what diets they should take more and which diets they should avoid. Vegetables, fruits, and whole grains, legumes, low-fat dairy products, and high-fiber diets, they are better, and low glycemic foods, they are better for diabetics rather than giving the high glycemic index foods or the processed nutrients like the potatoes and the mashed potatoes, the chips, and the fast food what we get from the different outlets. And the amount of fat in the diet should be reduced. Look at the Mediterranean style diet where you get a lot of unsaturated fatty acids in your diet. It is better. And decrease the amount of trans fat in your diet. So that's a better diet for the diabetics. The carbohydrate in the diet has to be a complex carbohydrates, and we have to reduce the calories as much as we can. And we have to consider using those foods which have a low glycemic index. Fructose, recently they say it's probably better than sucrose to use in the diet. It probably gives a better management of diabetes. The proteins are good for diabetics. Incorporate as much proteins as you can. And the other components are vitamin supplements, because if somebody has a long-standing diabetes, taking metformin for a long time, they tend to develop vitamin B12 deficiency. So these patients particularly should get B12 supplements. They should get a lot of antioxidants, and the sodium intake in diabetics has to be very low. This is a chart recommended by the American Diabetic Association. They see half of your plate should be non-starchy vegetables, and half of the 1/4 should be from the protein foods, and the 1/4 should be from the carbohydrate foods, along with the low calorie or no calorie drink. This all what I was talking, this is called medical nutrition therapy, or MNT. So it focuses on weight loss. It focuses on management of hypertension, dyslipidemia, as I told you, and the obesity. Because weight loss and insulin, it was seen and told in the introductory talk also. And when Dr. Amir Ahmed was telling you about the insulin resistance, here it comes into play. Weight loss, when there is a significant weight loss and the patient does his exercise regularly, it increases the insulin sensitivity and the control of diabetes becomes better. So how does physical activity benefit us? Number one, it helps us in weight loss. Number two, it reduces our cardiovascular risk, the risk of heart attacks and the heart failure. It lowers our blood pressure. And we are able to maintain a proper body mass. We have to reduce the amount of body fat. If we become more muscular, if the protein mass, the muscle mass is increased, no problems. But the body fat has to be got down. And it lowers our glucose in the blood and it increases our insulin sensitivity. And the drugs what we prescribe for these patients, they act better. American Diabetic Association recommends at least 150 minutes of exercise every week for at least over 3 days, and the gap should not be more than 2 days. So the exercise has to be regular. Not that we will do it for join a gym for a month or 2 months and then forget about it. That's not going to help us. We have to do it every single day. And we have to try to reduce our sedentary behavior throughout the day. As I told you before, how to park your car, how to use the stairs, how to go out with children and play. Those small things add up and they give a lot of benefit. Self-monitoring of glucose, what we call the glucometer. Every household now has a glucometer. All diabetic patients, we encourage them to buy glucometers. It gives you the level of glucose at a point of time, at that time when you give a prick into your finger. Whereas the hemoglobin A1C, which is done by the caregivers, done by the physicians, which is done by the laboratories, it gives the control of glucose over a period of time. As Dr. Amir Ahmed already told you, the lifespan of our red cells is 120 days. So it gives the mean control of blood glucose over 3 months time or 4 months time. American Diabetic Association recommends that HbA1c should be done twice per year. And those people, as I told you earlier also, where the diabetes is not properly controlled, we need to do it more frequently, almost 4 times a year. So what are the limitations? People who have got hemoglobin diseases, the hemoglobinopathies like the sickle cell anemia, sickle cell disease, the thalassemias, in those the hemoglobin A1c values are not reliable. And people who have got anemia, people who have got reticulocytosis, or people who have got received blood transfusions, or who have kidney disease with renal failure, in those patients, the hemoglobin A1c is not a reliable indicator of control of diabetes. What are the mean goals? If the hemoglobin A1c is around 6%, that means your mean glucose is around 7 millimoles or 126 milligrams. Likewise, when it goes to 7%, it goes to 8.6 and 154. Approximately with every percentage rise in hemoglobin, your mean glucose goes up by about 35 to 40 millimoles. So next we come now to the pharmaceutical interventions or the medications. As I told you, with development come our problems, and with development come the come the remedies also. So we have got different medications which target different pathways. There are some anti-diabetic medications which increase insulin secretion from the pancreas. These medications are called secretagogues. And there are some medications which reduce the glucose production in the body, especially from the liver and the muscles. We will come to it in the later slides. And there are some medications which decrease the rate of absorption from our gut. They get the glucose into our bloodstream slowly. There are some medications which increase our insulin sensitivity in the muscles. And there are some medications which increase the action of other hormones like the glucagon-like peptide GLP-1. And there are some medications which promote the excretion of glucose through the kidneys. As I told you, these are the target organs. Look at the liver. The liver, you have got the bigonides, the metformin which works here. In skeletal muscle, we have the TZDs, which increase the sensitivity of the insulin in the muscles. We have the pancreas, while we have the sulfonylureas, the glycides, the DPP4 inhibitors. They increase the release of insulin from the pancreas. And then we have the alpha glucosidase inhibitors and DPP4 inhibitors, which reduce glucose absorption from our GI tract. And then we have these TZDs, they increase the sensitivity of insulin in our fat also. And there are some medications like the glucose transporter inhibitors, which reduce the reabsorption of glucose from the kidneys, and the excess sugar is thrown out into the urine. The first and the most important drug what we use in diabetics with type 2 diabetes is metformin or the glucophage. It's a name everybody knows now. How it works, it decreases the glucose production in the liver. It usually helps at night because during the day we eat our meals and it increases our blood glucose in the body, and at the same time we are active and we spend this, we use this glucose. But at night the glucose is produced from the liver, and metformin takes care of this glucose in the liver. It does not allow it to produce more glucose, and it increases the utilization of glucose in the periphery by our muscles. And some people say that it also works in our GI tract, and probably it reduces the absorption of glucose also. It also helps in some modest weight loss. Maybe if you put the patient on metformin, he may lose 3 to 4 kilos of weight. It decreases the insulin levels in the body. It improves our lipid profile, and it extends the release form. They are better tolerated. Glucophage comes in two types now. One is the XR, and one is the routine one. So these are better tolerated. Why? Because I'll come to that in the next slide. We normally should start with lower doses, and then we should increase gradually, because if we start with higher doses, the patient may not tolerate it. He will develop the side effects, and then next time he comes, he will not accept this medication. So please start with lower doses. We have to start with lower doses. Now, metformin, it can be given as a monotherapy. Most of our patients, we start them on a monotherapy, and by time we have to add other drugs also. One of the side effects of glucophage is lactic acidosis, but it's very, very rare. So we don't encounter it very often. As I told you earlier also, it may cause B12 deficiency. So we have to look at the B12 levels in these patients, and they must get B12 supplements. Now, we should avoid using metformin. Metformin should be avoided in patients if the patient has got a renal failure and his kidney function has dropped. If his estimated GFR, the glucose, the filtration rate has come down to less than 30, then we cannot use metformin. And we have to halve the dose if the GFR has come down to below 45. And in people who have liver disease, we have to avoid it. Second group of drugs is the sulfonylureas or the insulin secretagogues, which increase the release of insulin from the pancreas. These medications also reduce our hemoglobin A1C by about 1 to 2%. They have a high initial response rate. That means they are fast-acting medications. They have low cost and convenient daily dosage. We can use them once a day. Before 30, 40 years, we didn't have the latest drugs of this class. We had the drugs which have gone off the market now because they used to have a lot of side effects, especially the hypoglycemia, which would stay for up to 3-4 days. But now we have better drugs available. The two which I have mentioned here, Emeril and Diamacron, they are better tolerated. What are the disadvantages? They can cause still hypoglycemia. So we have to be cautious. They have a tendency to gain weight as opposed to metformin. And again, these drugs has to be used with caution in people who have liver disease or who have kidney dysfunction. And people who have got coronary artery disease, we have to be very cautious in those also. Another group of drugs is called alpha glucosidase inhibitors. These drugs are not used in America and are mostly used in India. One of the drugs is glucobay or acarbose. Modestly reduces the hemoglobin A1C just 0.5 to 8%. It takes care of postprandial hyperglycemia because it does not allow the glucose to get into our blood very fast. But the predominant side effects are they have got a lot of flatulence and bloating. So that's why not used by many patients now. And they have got limited use in liver and kidney disease. Here in Kuwait, we don't use this group of drugs anymore. The fourth group of drugs is the DPP-4 inhibitors. What are those? The advantages, they are weight neutral. They don't increase, they don't decrease our weight. They have a very simple side effect profile. They don't cause hypoglycemia. There is no contraindication in heart failure and kidney disease. In fact, they are more favorable in people who have coronary artery disease. and they can be used as a monotherapy as single agents, or they can be combined with other agents. And among the side effects is nasopharyngitis and upper respiratory infection, and the cost. They are very costly, about $300 to $400 a month. So many of the patients cannot buy them, they cannot use them. In Kuwait, here we use Januvia and we use Galvus, and these two are medications are available here, and we are using them in our patients. The other group of drugs is, as I told you before, the drugs which increase the glucose excretion from the urine. They are called sodium glucose cotransporter inhibitors. And there are 4 drugs in this class of drugs. We are using 2 drugs in Kuwait right now. One is the Foxica and another one is Jardiance. These 2 drugs are available here and we are using them. They reduce hemoglobin A1C, they reduce the fasting plasma glucose and the postprandial glucose. Their action is independent of insulin. They don't depend on insulin, because whenever the body glucose goes high, they will throw it into the urine. So the risk of getting low glucose or hypoglycemia is very low in these patients. And they can help us some weight loss also, because when we are losing glucose in our urine, we are losing calories, and we are losing sodium also along with. So they help in weight loss, and they help in renal glucose loss, and they help in maintenance of blood pressure also, and they have a cardiovascular protection also. And some of the studies have seen that they are protective for our kidneys also. So what are the disadvantages of this group of drugs? Because when a lot of glucose is going into the urine, the chances of getting urinary infection and genital fungal infections is higher in these patients. And because the glucose goes out, along with glucose, a lot of water goes out. So these patients, they can develop dehydration, they can develop volume depletion. And some of the drugs, there is a risk of getting more amputations. And their cost is very high. This is the diagrammatic representation of these drugs. These drugs act in the proximal convoluted tubule, where 90% of the filtered glucose from the kidney, the glucose is filtered from the kidney. It reaches here in the proximal tubule, and from here 90% of this is absorbed and which is through these receptors. They are called SGLT2 receptors. And these medications, they block these receptors. So the glucose moves along and is excreted into the urine. Then we have another group of drugs which are not used anymore in Kuwait, very rarely used. They are called thiazolidine diones. We had 2 drugs. One was rosiglitazone or Avendia, which has been taken off from the market in everywhere in the world. The only drug left now is the pioglitazone or Actos. What are the advantages? They reduce the insulin resistance in the peripheral muscles. So the uptake by our body muscles, by the cells, is increased by these medications. They decrease the hemoglobin A1C by a good amount, it's 1 to 2%. The chances of hypoglycemia are not there. The cost is low. They are not very costly. And the dosage is very appropriate once a day. What is the disadvantage? Yes, there is some weight gain, and the onset of action is slow, because the results come usually we see in about 12 weeks. And they can cause water retention and edema. They can precipitate heart failure. So these medications are not recommended on those people who already have some heart problem and heart failure. And in post-menopausal women, they have seen that these medications can make our bones more fragile, because because of this osteoporosis, and they are more prone to get bone fractures. And there is a lot of noise of getting more bladder cancer patients with these medications, but the data are very poor. They are not so substantiating. And another group of medications is the GLP-1 or the glucagon-like peptide agonists. These are 2 drugs are available with us in Kuwait. One is the Trulicity and another is Victoza or liraglutide. Victoza is more convenient because it is once a day. We use it once a day. They are long-acting drugs. We can use weekly also. The Trulicity can be used once a week. They help in weight loss. About 2 to 3 kilos weight can be reduced with these medications. And again, the risk of getting hypoglycemia is very low with these drugs. How do they work? They number one, they reduce our hunger, so we don't eat much. They increase the amount of glucose production because they increase the GLP-1, glucagon-like peptide, and that's how they help us. What are the disadvantages? They have these nausea and other things, side effects. They may have diarrhea. And number 2 is we have to use them by injection. One of the drugs will be soon available, inshallah. It will come as an oral medication also, still not available. And these medications are contraindicated and they should not be given in people who have got endocrine neoplasia or people who have history of thyroid carcinoma, the medullary carcinoma of thyroid. And another disadvantage is they are very, very costly. Everybody cannot afford them. Then the last one is the insulin therapy. Now, as Dr. Amir Ahmed told you, diabetes is a progressive disease, in the sense that some patient, when we start him on treatment, he may be controlled by a slow dose of a single drug. By time he will need a full dose of this drug, and by more 5 years he will need addition of another medicine, and after another 2-3 years he will need addition of a third drug, and ultimately many of these people go into that we have to use insulin therapy in them because we cannot do away with insulin in these patients. But sometimes if the patient is lean and thin, so we might need to use insulin from the start of therapy. And individuals with hepatic or renal disease, as I told you, people where we cannot use those other medications, the oral medications, we have to switch over to insulin therapy. And patients, when they are in the hospital with some other problems, in the hospital we cannot use the oral medications, we have to use the insulin. But insulin is very safe. We can monitor the glucose and the hemoglobin A1C very nicely. But we have seen that physicians and the patients both have reluctance to start these medications. The single dose of insulin can be used. Bedtime doses are more effective. We have got newer insulins like glargine, what we call the Lentus, which is available with us in Kuwait. We use it as a single dose. It takes care of our glucose in the next 24 hours. But with time, we might need addition of other insulins at the time when the patient takes a meal. So ultimately, the patient needs multiple doses of insulin. And insulin may be used as a single agent, or we can add it on other oral medications, like we can add it with metformin, we can add it with the other groups of drugs which I have already enumerated, or it can be used as a single medication also. But people who have got underlying diseases like kidney failure and liver disease, then insulin is the only choice we use in those patients. And now we have got insulin infusion devices which are considered only for selected group of patients, because insulin infusion cannot be used by all ordinary people. The white collar job people, yes, the affluent people, they can use the infusion devices. So what should be our how do we start these therapies? If we have a patient who comes with a fasting glucose of 7 millimoles to 11 millimoles, we can use a single agent like metformin, or another agent. If for some reason we cannot use metformin, we can choose another agent. If the fasting glucose is 11 to 139 to 13.9 millimoles, then we have to use more than one agent. And if the fasting glucose is more than 13.9, they are unlikely to respond to oral therapy, and these people end up with insulin therapy. And sometimes in some, as I told you earlier also, we need to start the insulin as an initial therapy. There's a term called glucose toxicity, because if the patient is presenting with very high insulin, very high glucose, we have to try to get this glucose under control very fast, because otherwise this glucose gives a problem to the beta cells, which Dr. Amir had shown you in the diagram. They will lose those beta cells very fast if we don't tackle the high glucose levels in the beginning. This is a schematic representation. A patient comes with type 2 diabetes. We have to individualize the goal of therapy. We have to start with medical nutrition therapy, and we have to increase his physical activity. We have to promote weight loss, and we have to start with a single drug like metformin, and reassess the hemoglobin A1C after some time. And if he's well controlled, okay. He is not well controlled, we keep metformin and add on another agent, and reassess the hemoglobin A1C again. If he is controlled, well and good. If he is not controlled, we might switch on to a third agent, oral agent, or we might switch on to insulin therapy. And then there are some surgical remedies for the diabetics. One of them is the whole pancreas transplantation. Usually people who undergo kidney transplantation, we can do a pancreatic transplantation at the same time. The patient is already getting immunosuppressive therapy as a kidney transplant patient, so there is no added burden. So these patients do well. Or we can do a selective islet cell transplant, wherein we take the islet cells or the beta cells, inject them into the patient, and they settle down in the liver, and then they start producing the insulin for us. And then we have the autologous islet transplantation. Somebody who has chronic pancreatitis, who has calcification or stones in the pancreas, and he has severe pain, we need to remove their pancreas. So what we do is we take those islet cells and we inject them into the patient. This is called his own cells. This is called autologous islet transplantation. We take his own beta cells and inject into him, and in these patients, there is no need to give immunotherapy, immunosuppression therapy. And then we have the metabolic surgery or the bariatric surgery, where we do the gastric balloons, we do the gastrectomy, we do the sleeve gastrectomies, we do the bypass operations to take care of the obesity and the diabetes. And these therapies have shown a lot of promise, because many people who had diabetes, who had hypertension, who had very high cholesterol before the operation, many of them, they did not need any medications after they underwent these procedures. And then we have the stem cell transplantation, which is in the future. So that is my talk. Thank you very much. I hope it was not too much for you. We would welcome any questions from the audience, please.
There are so many questions in the chat box.
Yeah. Okay.
Okay, just a minute. Let me put a, sir, there is an online quiz. I am putting a link over there. Let the people answer, and meantime we can take the questions. It's not an issue. Okay, question. The link is posted in the chat box. Everyone can answer, and the first 5 will be taken care, and they will be recognized through a certificate of participation.
Okay, Ramana. So shall I take questions?
Yeah, you can carry on with the chat box. Thank you, Sardarji.
Okay. Sir Dr. Mohammed Yusuf Dar, there is a question posted by a few gentlemen. I will read question for you. Please explain about fatty acid related with diabetes. Hello, doctor.
Yes. I could not get his question properly, but the fatty acids are of two types: the unsaturated fatty acids and the saturated fatty acids. Now,
Yeah.
the unsaturated fatty acids are good for health. The saturated fats are not good for health. So we should try to reduce the amount of saturated fats in our diet and try to increase the amount of unsaturated fatty acids in our diet.
Thank you, sir. Hope.
I will. 1 second. No, I will just add on, please. Mr. Safdar, what you do is just read out the question. Don't direct it to the doctor. We will
Okay,
answer.
sir. Can you able to see?
Now 1 second. 1 minute.
group
1
chat?
minute. 1 minute, Mr. Safdar. Let me finish off with that fatty acid thing. There is a link between free fatty acid and the insulin resistance. So if the free fatty acid levels are high, it leads to insulin resistance, and that is why diabetes is seen. And so that's very important to keep the free fatty acid. And that's one more reason why, if you would have heard clearly when Dr. Yusuf Dar was talking, they prefer to give statins to people who are diabetic. And to reduce this, that way, free fatty acids in the body is linked to insulin resistance, increases insulin resistance, and thereby causing diabetes. That's the link, the main link. And rightly, as Dr. Yusuf Dar mentioned, saturated fatty acids are the harmful ones, and they are from animal sources. Unsaturated fatty acids, saturated is the fat that we get from the animal source. Yes, Dr. Yusuf, please.
Yes, and more importantly, fatty acids, I don't know, maybe the person who was asking the question, the fatty acids are more important when we are talking of diabetic ketoacidosis in children with type 1 diabetes, because they are very important. They increase the production of ketone bodies, and they are responsible for the acidosis in those patients. So they are more important in that situation when you have more fatty acids, because what happens when you don't have insulin in the body? In type 1 diabetes, there's no insulin. They have to take insulin from the outside. When there's no insulin in the body needs nutrition. So why does it get the nutrition from? It gets nutrition from the fatty acids. It mobilizes fatty acids from the fats. And when these fatty acids come to our blood circulation, they give us the problems what we see in diabetic ketoacidosis. Hope that answers the question.
Thank you, sir. Now I will take another question. One gentleman has posted 1 meal a day around 4:30 p.m. and rest of time fruit and vegetable soup is helpful to stay away from diabetes. I will read again.